Okay, so I know we've been chatting for 5-10 minutes, but I think I'd like to formally welcome everyone to the second of our collaboration in surgery presentation evenings. I'd like to welcome all the speakers for tonight. I'm Matthew Hadfield. I'm the chair of the Victorian State Committee. I want to welcome back and thank them for their time. To our other three judges, Patrick, Amy, Marilyn, thanks for your time again. I'd like to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and community, and we pay our respects to them and their cultures and to elders both past and present. Okay, we've had a chat about how things are going to work, so I think we will launch straight in. So what I'll do between each one is just make sure you can hear me, make sure you can share your screen, and then I'll tell you when to go. The first person presenting tonight is Jahan. Are you there and ready, Jahan?
Yeah, ready to go.
Okay, so whenever you're ready, you can make a start.
No worries. All right, so can everyone see that okay? All right. So thanks for being here to hear me talk about this. So what I'm presenting today is some of the research that forms a broader part of my PhD project, which is machine learning algorithms in surgery. This particular project was looking at predicting and risk profiling acute kidney injury. So surgery can be complicated, and cardiac surgery particularly so, especially with bypass. Postoperative acute kidney injury has been reported to affect up to 40% of surgeries, and we know that it increases mortality and morbidity. So the problem we were really trying to solve or look at here was whether machine learning techniques, modern machine learning techniques, can first of all better predict who's going to get acute kidney injury, and then secondly provide a better way of understanding the risk to that particular patient. Just to quickly contextualize things, machine learning is a broad term, but what it really encapsulates is regression techniques. And so that can be something as similar as a linear regression, which is pictured on screen, and hopefully you guys are all familiar with a linear regression, but this is generalized to much more complex models like a neural network or a decision tree model, but it's all really regression techniques. So you can go from simple models to very complex models. The data we were using comes from the ANSCATS database. We trained the models on about 96,000 patients, which represented about 97,000 surgeries. What we're looking at here is a graph showing you various decision boundaries across different models.
Part of your slides are missing. Part of your slides are missing. I don't know if everyone can see them. I can only see. I can see like the slide. It's not the full, not the slide show screen.
Okay. Let me just try.
Do you want to try again?
Yeah, I shall try again.
You'll need to put it in presenter view.
Can you see that?
Yeah.
Is that better?
That's better.
Okay.
That's much better, yeah. Okay.
Oh, sorry about that, guys. Essentially, what you're looking at here are the decision boundaries for a variety of machine learning algorithms. A logistic regression algorithm is the bread and butter of a lot of statistical analysis that's done in medicine, and it's built upon a linear model. And so you can see here it draws a straight line between red dots, which are AKI events, and blue dots, which are not AKI events. Going across to more complex models like a gradient boosted machine, which is an ensemble decision tree model, to a clustering model like the nearest neighbor model, and then a neural network model at the end, you can see it draws a much more complex boundary between the two groups. And so the question is, can we leverage this more complex boundary to create better risk profiles and bespoke risk profiles for patients? In terms of the performance, the predictive performance of these models, the complex models are just as good, if not slightly better, than the baseline models. They definitely beat the scoring tools that are out there. But interestingly, the performance to logistic regression is about on par. But you see that the decision tree models perform the best. But the most important thing when it comes to models is explainability. As clinicians, we want to know why a model is making a prediction that it is. A logistic regression model is easy to understand. You have a coefficient associated with each variable, and the bigger the coefficient, the bit more important that variable is to that prediction. So these are some of the, a graph showing some of the coefficients in the logistic regression model associated with various variables. But how can we get an understanding of why a model is making a prediction for the complex models? Well, we use a thing called Shapley additive values, which borrows from cooperative game theory. And essentially what you're doing is you're taking a prediction and you're working out from that prediction what all the various, how important each feature is. What's really cool about this approach is what we're looking at here are bespoke risk profiles. So you can take a prediction from someone who didn't get AKI, so in the blue space, so they had a 1% risk, and you can generate the risks that were important to that particular patient. You can take someone who had a sort of middling risk at about 5%, and you can generate those specific risks to that patient. And so what you're really doing with Shapley additive models, Shapley additive values, is you're interrogating the space that's unique to that individual patient around that decision boundary. And so that's really the power of more complex models. And as we learn more techniques around how to leverage those more complex models, we can generate more interesting things like this. Of course, we're a little bit limited in the sense that we don't have a big data set with a lot of modifiable risk factors. But as we collect a lot more data on things that can be modified before surgery, then we can look forward to leveraging these models in a more useful way. So maybe I'll just open up to questions now.
Okay, thanks very much for that. Have we got any questions from the judges? I've got one to start with, which is the time-consuming thing with setting up any of these models, neural networks, whatever, is the training phase, is the data entry. How did you go about that for your models? Is it a purely manual, time-consuming?
So I think for this particular data set, it's a well-established data set. So it's a national audit data set that cardiac surgery registrars enter. So it was already there, ready to go. But I acknowledge that when it comes to healthcare data sets, the challenge is in collecting them. And there are some really interesting things emerging in the literature, natural language models and that sort of stuff that are able to interrogate the electronic medical record and generate data sets. So that's an interesting space.
Okay, thanks. More questions? Okay, one final question then. So where is this particular system up to in terms of providing a useful clinical tool?
That's a good question. So at the moment, we're experimenting with some other techniques. So in terms of clinical practice, what you really want is a model that's able to leverage data that you have and not be fixed to a set of variables. And so you want something that's going to be able to be malleable in terms of what data is available. And so that's something that we're working on. And there are certain models called transformer models that we're training currently that's able to do that. And there are some decision tree models that are able to do that as well. I actually have one if you wanted to see it, but we probably don't have time. Yeah.
Okay, thanks very much, and thanks for your presentation and your time. Okay, we might, right in time. We might move on. Next person on my list is Ash Toki. Are you there, Ash?
Yeah. Can you see me?
I can see you. Hopefully, see your presentation shortly. Whenever you're set, you can make a start.
Sure. I'll just make sure it works. Here we go. All Right. Hi, everybody. My name's Ash. I'm one of the surgical trainees from the Royal Melbourne Hospital. My presentation is a regional experience of pancreatic duodenectomies in a regional centre in Tasmania. This operation is accepted as the only curative treatment for the resectable malignant tumour of the pancreatic head, and global literature has shown a relationship between decreased rates of complications and mortality in higher volume centres. However, due to the unique location of our population in Australia, a significant amount of our population relies on regional centres for surgical care. And moreover, the definition, as you can see in this graph here, of high volume centres does vary from country to country. And in fact, a study by RACS in 2018 showed that a caseload of 10 globally qualified as a low volume hospital in comparison to the median number in Victoria of 8 cases per year per centre. So Tasmania provides a unique situation for its patients, with half the population living outside of its 2 major cities, and LGH acts as a catchment area for northern Tasmania for a population of around 250,000. And whilst it provides a subspecialty hepatobiliary service, its location and size would place it within definition of a regional centre. So the purpose of our study was to assess whether pancreaticoduodenal surgery can be performed safely and maintain expected standards in our regional centre. We performed a retrospective review of data on all patients who underwent a Whipple's procedure between January 2011 and 2019. Patients who did not undergo curative resection due to unresectable disease were excluded from this study at time of operation, and data was collected from the general surgical database and medical records with statistical analysis using PRISM-8, and our primary outcomes were 30 and 90-day mortality post-operatively. We had a number of secondary outcomes as shown, including 1 and 5 year survival and our resection rate, length of stay and length of ICU stay. All patients who were considered high risk, borderline resectable or required vascular reconstruction as part of their resection were referred to a metropolitan high volume centre in Melbourne, in which case a relationship was in place, and all patients had staging CTs and MRIs prior to resection. These standard definitions were used as shown. And in total, over the 8.5 years, 46 patients underwent a Whipple's procedure at an average of 5.1 procedures per year. Demographics are shown, with 39 patients performed for malignancies and 7 performed for pre-malignant or benign conditions. Pylorus sparing operations were performed for most patients with a Bloom-Cart style anastomosis, and patients routinely had external drains placed across their hepatico and pancreatico-jejunostomies, which were removed at 6 weeks. 37% patients suffered a complication of any type, with 21 patients requiring a complication of clavien 3 or more, and 9 of these patients required a return to theatre, with 2 patients requiring more than 1 trip. The most common reason was for a wound infection. However, 3 patients required a revision of anastomosis and 3 patients for management of bleeding. We had 5 patients in total have pancreatic leaks post-operatively, of which 1 required a reoperation, and no patients required operations for their bile leaks. 2 patients did require transfer to a metropolitan centre for further management, both for radiological intervention we couldn't provide locally. 30-day mortality was 2.2%, with 90-day mortality 4.4%, with 1 death being due to an unexpected AMI and a second patient due to bleeding and sepsis after a transfer to another centre. And this compares to a Victorian cancer registry, which found a mortality at 30 days of 5.3%. Average length of stay was also similar to Victorian length of stays of 15 days. For pre-malignant and malignant lesions, R0 resection rate was achieved in 84.5% of patients, which is comparable to accepted outcomes in other medium and high volume centres globally. And for malignant resections, the 1 year survival was 69%, with a 5 year survival of 16.2% for all stages. A 2012 review of the data showed that in Victoria, 5 year survival post-Whipple's was in comparison a dismal 8.3%. Overall median survival was 20.6 months compared to a Victorian average of 16.3 months. And when stratified by T-stage, T2 disease trended towards a better survival than 5 year survival, both median and 5 year survivals as shown. In other countries, there is an improvement with centralisation and increasing numbers. However, the causal relationship between high volume alone and superior surgical outcome isn't quite certain for pancreaticoduodenectomies in Australia. We haven't been able to show a study in Australia effectively showing that relationship between high volume and mortality. Rather, the College of Surgeons has recommended a number of appropriate initiatives to set up to improve outcomes. These include providing evidence-based personal care to patients' risk profiles and higher risk patients receiving care in hospitals with a high staffing and equipment, continued surgical training for surgeons, standardised post-operative care, supporting root cause identification and decreasing failure to rescue, and establishing partnerships between high and low volume centres. This is seen in the relationship between Launceston General Hospital and Royal Hobart, as well as the Austin Hospital, where complex patients are discussed between teams to ensure consensus in regards to the management of disease and location of surgery. In post-COVID environment, we find ourselves in, at least in the short term, interstate and long-distance travel for patients with complex needs has become more challenging. And in this study, we've been able to show that in pancreatic cancer, the appropriate structure of care within our hospital and between services, operative services can be provided in a regional centre to an appropriate standard for complex surgery. Thank you.
Okay, thank you for that. That was great. Questions? Anybody got a question to start with? So Ash, what's your, so clearly the pressure continues to centralize and urbanize this type of procedure, what they call the low volume procedures. What's your conclusion about what constitutes low volume in Australia compared to most of the international literature?
Yeah, I think that unfortunately, we're never really, unless in, well, for example, in Victoria, in a single year, we do a total of about 100 pancreatic duodenectomies. And in Victoria, we have 10 centres doing 100 cases. So in comparison to Asia, where a high volume centre is considered 50 to 100 and above, we're never really going to be able to maintain those numbers. But I think similarly to trauma, we can show that if we're able to implement the appropriate structures and relationships with centres, we can maintain standards as high volume centres. The mainstay, I think, to this is appropriate training of both surgeons and the teams around that. And that might be as part of kind of building relationships with high volume centres overseas, but also within Australia itself.
And just as a follow-up, in terms of the Melbourne centres carrying out the same procedure,
yeah,
how many of them are doing more procedures per year than in Launceston?
So the median in Victoria was 8. So 5 centres were doing more than Launceston, 5 were doing less. And the most amount done per year in Victoria is 20 a year.
Okay. Thank you. Any more questions from the other 3 judges? Wait 5 seconds and then you're off the hook. Okay, thank you very much. That was great. Next on the list, I've got Sandy Sue. Are you there? And are you ready?
Yes, I am. Thank you.
There you are. Okay, if you want to share your screen, and then whenever you're ready, you can make a start.
Yep. Okay. Choledocholithiasis is common and occurs in 3 to 20% of patients receiving a cholecystectomy. Current management includes single-stage and 2-stage approaches. So single-stage meaning laparoscopic common bile duct exploration or on-table ERCP. Alternatively, pre- or post-operative ERCP as part of the 2-stage management may be performed with or without antegrade biliary stenting. In some rural or regional sites, some options pose additional challenges due to lack of resources, for example, lack of MRI machine on site, as well as insufficient resources or staffing to perform intraoperative ERCP. Our study focuses on West Gippsland Hospital, a 144-bed hospital without an ICU and without an on-site MRI. Its closest hospitals include La Trobe Hospital and Monash Health, with La Trobe Regional Hospital being 1 hour away. The MRCPs can range from 1 to 2 days in terms of a long wait list. And the current structure of general surgery at West Gippsland Hospital include 5 surgeons with a general surgery on call with different subspecialties. And our supervisor HPB surgeon who specializes in, who's proficient in biliary stenting, guided us with our current aim, does limited access to investigation and management options in a small regional hospital affect length of stay. And we hypothesize that patients who required MRCP or ERCP for investigation or management of choledocholithiasis had a greater length of stay compared to those who underwent biliary stenting or laparoscopic bile duct exploration. The way that we did our study was a retrospective case study, which identified all adult patients admitted under the surgical unit for diagnosed biliary pathology between the dates of 1st July 2019 to 30th of April 2020. And these were the data that we collected. In terms of, there were a predominance of female patients, 73%, and the mean age was 52 years, with a high bilirubin mean of 35.7. 53% of these patients underwent an operation, and 16% of those also had inter-hospital transfer. In this table, you can see that we identified 200 patients, of which 50 were discharged and 1 was transferred to ERCP. 149 were ultimately admitted to hospital and underwent these investigations, and our outcome measured was mean length of stay. With length of stay, the average length of stay for patients requiring ERCP and or MRCP were 5.5 days, compared to those who only required MRCP were 4.4. There was 1 patient identified in the case mix who required biliary stenting with a length of stay of 3 days, and those who didn't require any inter-hospital transfer were 2 days. So in our discussion, we'd like to purport that biliary stenting or exploration is a safe and more efficient alternative to pre-operative MRCPs. Single-stage management may be of benefit in reducing the number of procedures needed without an increase in complications. Furthermore, this reduces costs associated with surgery and bed days, and supported by these 2 articles as well. Furthermore, additional cholangiogram by a preoperative MRCP would provide limited diagnostic or therapeutic benefit, as those patients in whom choledocholithiasis would be suspected preoperatively could likely be safely operated on with either intraoperative antegrade biliary stenting with aim to perform outpatient ERCP for the removal of stone, or without biliary stenting, in which case inpatient ERCP would need to be organised, but without the need of MRCP in either case. In our case mix, there was 1 biliary stent placement identified, and this could reflect a hesitancy to perform biliary stenting due to surgeon preference or skill set. It could also mean that there was a lack of necessary equipment, for example, a shortage of biliary duct stents, as demonstrated in a different case. So our limitations of our study include our small sample size and the fact that it was retrospective. To counteract this, future studies may include patients admitted over longer timeframes or incorporate multi-center involvement, including multiple regional and rural hospitals. So finally, we concluded that limited access to investigations and management options not available at the hospital site was associated with increased length of stay, and that reducing number of preoperative MRCPs can reduce length of stay and therefore reduce costs, because biliary stenting in suspected cases may also provide reduced length of stay and allow for discharge while arranging ERCP as an outpatient. Thank you.
Thanks for your talk, Sandy. So how has this project changed your approach to working in regional hospitals?
Thank you for your question. I'm Sandy, one of the, and I was a surgical intern during that rotation. So I think that going forward, it can be recommended to avoid preoperative MRCPs if the patient presents cholangitic or with likely with the current presentation, and also that we would so just to conclude that question, to avoid preoperative MRCPs, because we don't really see any therapeutic benefit. Thank you.
So Sandy, what strength of network was there between the small regional hospital and some of the larger centres in Melbourne? Was there an established network, or did it rely on you as the intern getting on the phone and trying to find somewhere in Melbourne to send your patient?
Okay. Thank you for your question. So with the preoperative MRCPs, we would refer to Latrobe Regional Hospital. So and then for the people who required an ERCP would also have to liaise with Monash Health. So those two hospitals networks were who we communicate with most frequently.
Okay, and was that an established link that they would automatically take, or did it require an individual referral every time?
Yes, it required an individual referral every time.
Okay. Anyone else got any questions? Okay. Thank you for your presentation. That was great. So, Lewis, you're next on my list. Are you there? Lewis Karapanos.
Yeah, I'm just putting my presentation on now.
Okay. Yeah, getting there?
Can everyone set up?
Yeah, that's great. So whenever you're ready, you can make a start.
Night blindness, difficulty driving and playing sports, peripheral vision loss, visual distortions, and eventual total blindness. These are the typical sequences of symptoms that individuals with retinitis pigmentosa are characterized from early adolescence. Retinitis pigmentosa is a genetically inherited disorder characterized by the progressive loss of rods and cones in the retina. With the exception of gene therapy, working for only less than 2% of cases, there is no effective treatment for the disease. This is where the Bionic eye comes in. So what is the Bionic eye? So it captures light from the environment and it gets processed in a camera that is mounted on glasses. The electrical signal travels through the glasses and then travels down below the neck to an image processor, which is listed out of screen, then travels back up and enters the skull through a percutaneous connector, and then enters an implant in the retina where it electrically discharges neurons in there. So in retinitis pigmentosa, it is these cells here that are damaged, so the photoreceptor cells, the rods and the cones. And what the Bionic eye tries to discharge, it tries to discharge these cells here, these ganglion cells in the innermost layer where they're still intact. And so with the Australian Bionic eye, the electrode is placed just superficial to the choroid layer of the eye, which is the blood supply. And to the right of screen, that's where you have the electrode. So that is the electrode that is placed in that layer behind the eye. So the Bionic eye produces vision that is characterized by balls of light or phosphenes. And evidently this sort of vision, it doesn't produce high detail vision. It's not at the level we can see faces yet. And so lab tests measuring visual acuity do not accurately represent the efficacy of the device. So this leads to my aim, which is to investigate how the Australian Bionic eye improves orientation and mobility and other activities in the real-world setting in patients with late stage of the disease. So what we did was actually implant the device at -8 weeks. And then after 8 weeks from when we implanted the device, we made the participants undergo fitting and training. And this was when the device was initially switched on. So there were 4 participants in the study and we implanted the device in only one of the eyes. And then we took measurements at 17, 20, 32, 44, 56 and 68 weeks. And the measurement tool we used was called the FLORA. So it's the Functional Low Vision Observer Rated Assessment Tool. And there are 2 components to it, one being qualitative. And we asked the participants 13 self-report questions of which they responded to concerning how the device benefited them. And as you can see, the text highlighted in blue, such as finding part of the husband's body in the cafe, that represents increased social interaction. And the comments in green, such as more energetic, happy and positive, represent a positive psychological change due to the device. Now, the other component of the FLORA is a quantitative component. And in this component, the participants had to complete 35 functional visual tasks that were rated by an orientation and mobility specialist. So 1 was designated as impossible to complete, and 4 represented very easy to complete by the participant. And in this graph, red represents impossible and purple represents easy. And as you can see, over time, the tasks become easier to complete. So the first column is pre-surgery, the second column is week 20 with the device on, and the last column is week 68 with the device on. And you can see how that there's a progression of improvement there. But there's no way to tell from this graph if there's a training effect or not. So what we did is we actually averaged out all the scores when the device was turned off for each task in a domain, and then subtracted it from the mean on scores. And as you can see, improvement was still seen in 3 out of the 4 domains. So visual orientation, daily life, and interacting with others. In visual mobility, where the patients are required to avoid obstacles in the environment, there was no real change with the device on when compared to off. And all those values there are centered on the red line of no effect. Now, when we actually averaged out all the tasks over all domains, you can see that most of the participants produced scores that were better with the on condition than the off condition. And as you can see, there's a trend of improvement over time. So this suggests that the patients are learning to integrate that extrasensory information better over time. They're learning to use the device better. So in summary, the device demonstration improved overall completion in functional visual tasks, especially in the visual orientation and daily life domains. And there is evidence to suggest that the participant is learning to use the device better over time. The qualitative data shows that the device not only allows enhanced motivation, but also allows to close the gap with regards to equal access to information with other people. The device can be thought of as acting like another walking stick to these patients, and hence shows potential utility in everyday life. Thank you.
Thanks for that. That's really interesting. It's quite a groundbreaking piece of work, isn't it? Questions from the panel?
So what was your role in all this, Lewis, in terms of the Bionic eye?
Yeah, so basically I'm a medical student on the project, and the task I had to do was actually collate the data on a statistical software called Starter, and also actually help with the assessment as well. So I was with the orientation and mobility specialists collecting the data and actually helping to determine if the tasks completed by the participants were easy or difficult. I was responsible for producing all the graphs and the stats.
Was the you said the device, obviously it's an early device and things will develop. Was the device the same all the way through the study for every one of the study participants?
Yeah, so exactly the same device. This is the second generation device.
Okay.
So the first generation had 22 electrodes, and this device has 44, so we've doubled it. We've actually tried using other systems to increase object contrast separation, but that wasn't the main device that we were testing in the study. That's for future research.
Okay. Thanks. Anybody else got a question? Okay, that was great. Thanks for your presentation. I really enjoyed that.
Thank you.
Okay, where's my list? Carlos, you're next. Carlos, number 1 is next on my list.
Thanks, everyone. Hold on, just share my screen and start the video.
See you. Let's see if we can see your screen.
Okay, so there you go. Can you see that, guys, everyone?
Yeah, if you just go to presentation view, then we'll be good.
So good evening. My name is Carlos. I'm a PhD student at the Peter Mac and a general surgical trainee as well. And today I'd just like to take the opportunity to present 2 pieces of our work. Actually, this is the first clinical audience that I'll be presenting to, so it'll be great if I can get some feedback in terms of any questions. So I've got no disclosures to add to. So the first project really looks into the role of tumor-infiltrating lymphocytes in cancer. So the understanding of cancer has actually developed over the last 10 years. In fact, it's no longer just a tumor problem, and it's also a problem of the host or the human immune system. There's a balance between immunosuppressive and anti-tumor factors that play a role ultimately to lead to a tumor to regress or metastasize. And so most recent work that was developed by Jerome Gallen, a scientist, looked at the role of CD3 and CD8 tumor-infiltrating lymphocytes within the tumor microenvironment of colorectal cancer. So essentially what he did was he labeled these cells with immunohistochemistry and really quantified them within the stroma and the invasive margin of the tumor. And what he found was that the degree of infiltration and actually correlated with the patient's prognostic outcome a lot better than the traditional TNM classification system. And so this led us to the questions of what are the significant immune cells that actually predict outcome in esophageal cancer? Much work has been done in quantifying these TILs in esophageal cancer, but results are quite all over the place, and there's no real solid conclusion. So what we decided to do is to look back at our archival samples and really interrogate the tumor microenvironment and look at the TILs within each specimen. And we did this for 58 samples in total, according to a TIL quantification protocol that's been established from an international cohort. And essentially, we quantified the TILs in two separate compartments: the stroma, or the area surrounding the tumor nest, and the TILs within the tumor nest itself. The third score is an overall score, and this was conducted by one pathologist. And so, right to the crux of our results. So we quantified the TILs in the biopsy or the pre-treatment specimen, as well as the surgical resection specimen. And in adenocarcinoma, what we can see here is that there are a portion of patients who mount an immune response demonstrated by an increase in their TIL count after neoadjuvant chemoradiation. However, you can see the vast majority of them actually have a decrease in their TIL count. And when we look at the patients who, in terms of their progression-free survival, of patients who actually have an increase in their TIL count compared with those that have a decrease, we see that there is quite a marked difference in progression-free survival. And this is solely on a univariate analysis, so we need to validate this in a larger cohort. So the next thing that we did was we looked at the overall TIL count in surgical resection specimens. Now, we know that the tumor regression grade is or can be prognostic in terms of recurrence in esophageal cancer. We can see here in our cohort, this Kaplan-Meier curve demonstrates that those with a complete response at TRG1 fare a lot better than those with a TRG4 to 5, which is a incomplete or a very poor response. However, if we look at these two lines, the blue line and the green line, TRG1 and 2 to 3, they're the group of patients that correlate to a partial response. The delineation between their survival is not so marked. So we looked at this subgroup and applied the TIL quantification system, and we can see here that by looking at the TILs in conjunction with the TRG, we're also able to substratify the survival of this cohort into a more obvious group in terms of recurrence. And we see here that the patients who have a higher TIL count fare a lot better, not surprisingly. And this was significant on multivariate analysis using nodal status as one of the other variables. Now, the next thing that we noticed when we were quantifying these lymphocytes was that we noticed quite a lot of neutrophils. And so we took a step back, re-quantified the whole lot in terms of neutrophils, and found this very startling trend. Essentially, if you've got a lot of neutrophils in your surgical resection specimen, this is a bad prognostic indicator. And the presence of neutrophils actually correlates with the pathological response, as well as the chance of recurrent disease. And most of these neutrophils exist in the stroma or the scar of the tumor where the tumor actually was. And you can see here from the orange arrows, these are neutrophils. And here are the islands of tumor that you can see. And so this was also significantly independent of other known prognostic factors. And so in summary, we have a preliminary understanding here that an increase in TILs is protective for recurrence in adenocarcinoma, but more work needs to be done in order to decipher what the underlying mechanisms are in terms of neutrophils. And so with that, I'd like to end and take any questions.
Okay, thanks very much for an interesting presentation. Questions from the panel?
So what's next for your research, Carlos? You said this was part of a bigger project.
Yeah, so it is part of a bigger project. And so the most interesting thing that we found thus far is this presence of neutrophils. And the tumor-associated neutrophils have not really been examined well in many solid organ tumors. And the reason with that is because once you take out a tumor from a resection specimen or from its native organ, these neutrophils die really quickly and they just granulate, right? So we don't, and so the next endeavor would be to really investigate how these neutrophils are actually causing a bad outcome. And so what we've done, I haven't shown it here though, what we've done thus far is we've done some analysis on the RNA of the surgical resection specimens, and we've noted that, albeit early, that these neutrophils somehow impede the function of these CD8 T cells. And so now that'll be a next step, and this will hopefully lead to possible therapeutic outcomes in these patients, because it is, esophageal cancer is a dreadful disease, and not many patients respond to current treatment.
Is your gut feeling that the neutrophils are causal, or more a reaction from the fact that those particular subset of cancers are bad?
So, yeah, that's a very good question, because a critique of this finding is the fact that, okay, hold on, you perform surgery and you anesthetize a patient, neutrophils will inevitably infiltrate because it's quite an inflammatory response, right? You're causing insult to the organ. And so, yes, that is it may be a cause of the surgery itself. But what we're finding is that in these surgical resection specimens, which have been processed for about 4 hours or so, the neutrophils still exist. And in other tumor models, such as in renal cell cancer and even in ovarian cancer and in breast cancer, they too have found that these tumor-associated neutrophils somehow cause a degree of immunosuppression. And that's different to the neutrophils that come in because you have like an acute reaction or a bacterial infection, in which case, that's a different set of neutrophils. So it's still quite early, and these findings need to be further validated, essentially.
Carlos, thanks for your talk. I have a question relating to why did you specifically want to look at esophageal cancers? It's not the commonest malignancy that we're dealing with in the community. Your research is going to be applied to sort of achieve the greatest, common good. Wouldn't it be more appropriate to look at some of the commoner cancers?
Well, yeah, that's another good question, Marilyn. But well, to be honest with you, the reason why we chose esophageal is because I have an interest in upper GI, and eventually I want to be heading in that direction. And I'm in an esophageal lab, basically.
And are you aware if this is being studied for other cancers?
It has been studied for other cancers, most commonly in ovarian cancer. There, what they found is that these neutrophils, when they die, they release these nets. So they extrude their DNA, basically, through these net-like structures. It's like a spider web, for more of a better word. And they trap the cells in the immune cells in that web, thus causing, disabling them from, basically enacting their cytotoxic effect. So ovarian cancer has been looked at, but to my knowledge, there's only been one study in esophageal cancer, more specifically in esophageal adenocarcinoma. And look, I know, it sounds quite idealistic, but we're trying to find this magic bullet to try to help all those patients who don't respond, because with the current neoadjuvant treatment regimen, only about 20% respond. So yeah, it's a rather hopeless cancer.
Thanks.
Okay, thanks for that presentation. I really enjoyed that one. We'll maybe leave you on screen and you can.
So I'll share with you the other one.
Yep.
Is that one there? Hold on.
It.
I just need to enact the presentation. There we go. So the next piece of work is looking at circulating tumor DNA in esophageal cancer. And this is all part of a bigger project to look at biomarkers of the assessment of response to treatment in esophageal cancer. So as a tumor grows, its cells undergo a rapid turnover of cell death and renewal. And when this happens, these cells release DNA fragments into the bloodstream, and healthy cells alike, like cells that line the intestine, the villi, they also undergo a rapid turnover, and they also release DNA into the bloodstream. But with current next generation sequencing technologies, we're actually able to delineate and differentiate between tumor DNA and germline or healthy DNA. So the advantage of obtaining a patient's blood sample is that we're actually able to measure the DNA that comes from the tumor here, as opposed to comparing this to a physical biopsy, in which case you may miss certain cells that compose the tumor itself. And by taking a bit more accurate picture, theoretically, we can then follow the course of how this tumor progresses during a patient's treatment. And so much work has been done on circulating tumor DNA in breast cancer and also in colorectal cancer. In fact, there's a trial going on, but not much work has been done in esophageal cancer. And so we hypothesize that the use of ctDNA in esophageal cancer can have three uses. And this is according to a patient's journey. So it may improve pretreatment staging over conventional imaging alone. It also can be a tool to monitor response to treatment and also serve as an early detection of recurrent disease. So what we've done is I've collected samples from de novo patients who have had no treatment, and during their staging laparoscopy in 2 hospitals in Melbourne here, I've taken their biopsy, tumor biopsy, as well as their plasma DNA, and extracted genomic DNA from these 2 samples. And I've basically ran them through a well-established pipeline to look for 9 of the most common mutations in esophageal cancer and sequenced them using an Illumina MiSeq sequencer. So to the main results. We had 52 patients with usable tumor biopsies, and 45 patients had mutations in their biopsy. And so the next question we asked was, can we use this information to prognosticate and improve the staging over conventional imaging alone? We know that patients with nodal positive disease on PET and CT do badly, but how about those patients with nodal negative disease? Because there are a subset of patients who are node negative who still do as badly. So when we apply the status of ctDNA to these patients who are node negative, we already begin to see a trend that those patients who are ctDNA positive do a lot worse than those who are negative here. So the next step would be to see if we can look at the kinetics of ctDNA during a patient's treatment. This is an example of one patient who underwent neoadjuvant chemoradiation. As you can see, their ctDNA amount went nicely down and down to 0 after they've had their surgery. And this is corroborated by the fact that they had a restaging PET-CT after their neoadjuvant treatment, exemplifying partial metabolic response. On the other side of the coin, we can also use ctDNA to monitor patients who will not respond to treatment. This patient had definitive chemoradiation for their esophageal cancer. And you can see here, after they finished their definitive chemoradiation, we restaged them and unfortunately found progressive nodal metastatic disease as delineated by these yellow arrows there. And we took a sample of plasma soon after, demonstrating an increase in their ctDNA load. So the last thing we want to look at is, can we use ctDNA as a marker of surveillance after a patient has had treatment? So in this particular patient, they went straight to surgery for their cancer. And during their follow-up period, we took 3 separate blood samples, as you can see here. And at about 250 days, the ctDNA allele frequency went all the way up to just above 20%. And 3 months thereafter, this patient actually presented to the local emergency with nonspecific abdominal pain, after which a subsequent CT and PET demonstrated hepatic metastasis. And so what's very interesting is that if we follow up those patients who had a recurrence, they had developed actually new mutations in their plasma. And this was quite significant compared to those patients who had no mutations. These patients were basically disease-free. And when we look at the characteristics of these new mutations, these 3 common genes pop up. And I'm still in the process of investigating the significance of this, but it seems that they are all new genes related to tumor suppression. So essentially, in summary, this is yet preliminary evidence, but it begins to show promise that ctDNA may improve prognostication over conventional imaging alone in the pre-treatment stage. And also, it also shows promise as a possible marker of recurrent disease after someone has undergone definitive treatment. And with that, I'd like to end and acknowledge the following people.
Thanks for that. That's another interesting talk. How do your findings translate clinically in the near future?
So I think so we'll think about it in those 3 phases, for more of a better word. I think in the first phase, and that is to improve the patient's pre-treatment staging, the ability to actually identify micrometastatic disease over conventional imaging alone, such as PET-CT, will help us tailor specific treatment regimens for a particular patient. So how I might envisage that may help? Well, at this point in time, there are separate trials around the world going on in terms of implementing neoadjuvant immunotherapy as an adjunct to chemoradiation. So for example, if we identify patients who are at high risk of recurrence, we may then be able to administer immunotherapy to these patients who are at high risk of their disease coming back. That might be one way. And I think the other nice thing is that the second way of doing things is using ctDNA as a biomarker or as a surveillance tool. I don't know exactly at this stage how often you should be taking the blood samples as a method of surveillance, but in the future, perhaps a clinical trial could be designed where, blood samples are taken every 3 months compared to, 6 monthly imaging, for example, to help ascertain what is the most efficient time course or frequency of taking blood samples for ctDNA. But at the moment, it's still quite early, and we need to validate these findings.
What have you had any collaboration with other labs or other countries about this?
The specific assay we're doing is a boutique assay, and our lab has actually developed that because And we haven't actually collaborated with any other labs, but we have collaborated with other hospitals in terms of recruiting patients. And yeah, definitely I'm seeking for more collaborations if anyone knows any, just to help build up the numbers, because it's not, esophageal cancer, it's not very common here. Well, compared to melanoma and colorectal and, breast. So yeah, definitely.
Has that been looked into other neoplasms and other cancers?
Yeah,
same idea. I mean, it just sounds very much like a PSA situation here.
Yeah, so with circulating tumor DNA, it's been looked at quite extensively, in fact, in breast cancer. And there's a trial in colorectal cancer called the Dynamic 3 trial that's looking at circulating tumor DNA for surveillance in colorectal cancer. Yeah, so it's not, it's quite common is what I'm trying to say. But if you compare the different assays of circulating tumor DNA within each tumor stream, that itself can be quite different, because as you know, each tumor is quite unique, and each assay, you have to tailor the assay to the type of tumor that you have, essentially. So yeah.
Okay, thank you for 2 interesting presentations.
No worries.
The next presenter on my list is Emma. Emma, are you there? Emma Holland.
Hello, sorry. Yes, I'm here. Let me just share my screen with you. Perfect.
Whenever you're ready.
Wonderful. Thank you very much for having me today and enabling me to present my research entitled Pathology in Colon Cancer, Prognosis and Uptake of Adjuvant Therapy, the PICkup Study. I'd like to also acknowledge and pay my respects to the traditional elders of the land, and my respects to the elders both past, present and future, and also acknowledge my colleagues who have assisted me with this presentation, Miss Irene Law and Dr. James Wei-Tatto. So as we know, colorectal cancer remains an important health issue in our community. In 2020, 15,494 new cases of colon cancer will be diagnosed. The current standard of care for colorectal cancer focuses on early detection, staging, and treatment planning, with MDT playing a vital role in this process. Whilst many agree that there is a role for adjuvant therapy for some grade 2 colon cancers, it remains unclear which patients would benefit from treatment. Currently, decision-making in patients with stage 2 colon cancer is individualised to patient preferences and comorbidities. The current ESMO guidelines suggest that patients with stage 2 colon cancer with high-risk features, such as lymph node sampling, less than 12, poorly differentiated tumours, presence of vascular, perineural or lymphatic invasion, tumour presentation with obstruction or perforation, and PT4 stage should receive adjuvant therapy. But here at home, things are a little bit different, and the current stance on adjuvant therapy for stage 2 colon cancer is a little bit less clear, our current guidelines stating that the optimal approach is uncertain and adjuvant therapy should only be considered in high-risk patients on a case-by-case basis. So what our study is really looking to do is to understand the current specialist attitudes towards colorectal cancer and the pathological features in colon cancer, with a view to being able to predict prognosis and guide which patients may benefit from adjuvant therapy. The Pathology in Colon Cancer Prognosis and Uptake of Adjuvant Therapy PICkup questionnaire was distributed to colorectal surgeons, medical oncologists and pathologists across Australia and New Zealand. A 5-scale Likert score was used to assess attitudes towards 23 pathological features for prognosis and 18 features for adjuvant therapy. Summary statistics and weighted averages were provided for all pathological features, and data were then analysed using a rating scale and graded response model in item response theory on Starter in version 15. So the results of our study are significant. So we can see that 164 medical specialists were involved in the study, and this comprised 45 oncologists, 86 surgeons and 33 pathologists across Australia and New Zealand. And of these 164 specialists, 80.5% regularly attended MDT. So in 1999, the American College of the College of the American Pathologists released a consensus statement on prognostic factors and colorectal cancer. And in this statement, prognostic factors were categorized into different subgroups based on the strength of published evidence. So for example, category 1 evidence included factors with a proven prognostic value, such as, for example, regional lymph node metastases. This was very helpful in helping us to assess our results. So our raw data here that you can see demonstrates the percentage of specialists who have recorded likely or definitely when asked if pathological features influence prognosis in colon cancer. And what we can see here is that distant metastases, tumour rupture, involved lymph nodes and distant metastases in the liver, including as well as involved surgical margins and lymphovascular invasion, all score very highly. And this correlates to our IRT modelling as well, with the most important pathological features for prognosis in colon cancer being distant mets, tumour rupture, lymph node metastases and liver mets. So the next table looks at our item response theory, and you can see here that there are 9 factors that score grade 1 evidence. So to give you some context about item response theory is useful in scoring tests and questionnaires, and is based on the theory that there's a relationship between the individual's performance on a questionnaire or test item and the individual's level of performance overall. And this is then incorporated into a scaling system. A score of 4.5 and above is a grade, essentially category 1 evidence. So using the American consensus statement, we were able to assess a grade. And you can see here that we've got quite a strong confidence interval as well. Similarly, when we look at the percentage of specialists who have recorded likely or definitely when asked if pathological features influence recommendations for adjuvant therapy in stage 2 colon cancer, you can see that tumour rupture, involved margins, LVI, and the involved radial margin are also important. And again, we've seen correlation with our IRT modelling, which is demonstrated here. So based on the responses of our specialists, what we can see is that for patients with stage 2 colon cancer who have tumour rupture, there's an IRT score of 4.55. This correlates with grade 1 evidence as per the consensus guideline. And in this context, our respondents would definitely recommend adjuvant therapy for these patients. What's really interesting, I think, and where further research could be done, is in the lymphovascular invasion and microsatellite instability. So lymphovascular invasion scores 4.25. This is approximately a category 2B, 2A evidence. And more work could be done here. So this study provides the most current status on the importance of pathological features and prognostication recommendations for adjuvant therapy in Australia and New Zealand. And we hope that this information can be included in cancer MDT discussions.
Okay, thank you very much. Emma, if you want to turn your camera on. Has anyone got any questions?
Emma, I have a question. Thanks for your presentation. The issue with tumour spillage.
I'm so sorry, you've just dropped out. I hope it's not my end. Our internet's a little patchy.
Can you hear me now?
Yes, I can. Sorry.
That's okay. So the issue of intraoperative tumour rupture is often dependent. Well, there is an argument that that's dependent on the skill of the surgeon.
Mm-hmm.
Where do you think that this sort of, risk stratification fits in terms of being applied to a cohort of surgeons, say, across Australia, which have got different levels of experience and different skill level? Because it's going to be a confounder, isn't it?
Absolutely, I think you're right. And I think this is one of the limitations of the study, is that obviously it's reflective of specialist attitudes, and these confounding factors, as you mentioned, yes, it could certainly be a factor, and it would be interesting to look into that point in the future.
And so sadly, still the uptake of cancer MDT meetings varies even across the country. So clearly, that's also a confounding factor in your application of your results.
Absolutely, and I think whilst we all strive for what is best practice care and the inclusion of MDT as part of our treatment for patients, this study has been developed in response to, I suppose, a best practice algorithm. Yes.
Emma, I've got one other question. Internationally, are you aware of any, similar sort of risk stratification protocols that are utilised? And if so, what's their success rate been in terms of prognostication?
This is the largest study of its nature in the Australia Pacific at the moment, and I am not aware of any other international protocols that are currently looking at this particular question. I know there's some more information being discussed regarding the role of MSI in colorectal cancer and its prognostic value, because of course treatment of stage 2 colon cancer is so, I suppose, ambiguous at the moment. So it is a hot topic in research.
Okay, thanks.
Okay, thanks for your presentation. That was great. The next presenter on my list would be Melody Koo. Melody, are you there and ready?
Yeah, just going to share my screen.
Yes, I really, that last question really well. That was a tough question. Well.
Okay, whenever you're ready, that's great.
Perfect. All right, so before I start my presentation, I would like to ask everyone to imagine if you're standing in the middle of a rural town with $13 in your pocket, what do you think is the best thing you can do for population health for that rural town? So my name is Melody Koo. I'm going to present my project on ultrasound screening of AAA by junior doctors in Australian rural hospital setting. This was a pilot study initiated by myself and my 4 other fellow interns while we did our internship in rural South Australia. So a bit about AAA. Abdominal aorta should be within 3 centimeters in Caucasian population. And the prevalence of AAA ranges from 3 to 10%, and it increases with age. The mortality rate of ruptured AAA is really high, it's up to 90%. Currently, there are several first world countries with targeted screening program. However, it's not the case for Australia, and this was on a large randomized controlled trial performed in 2016 on metropolitan Western Australia. And they mentioned a point that it's challenging to deliver the screening program to geographically remote populations. So it came to our mind, and for junior doctors who are currently working in a rural hospital setting with limited health resources, is it possible for us to perform ultrasound screening of AAA for the population? So we're based in Whyalla, which, as you can see on the Google map, it takes 4 hours to drive to its closest tertiary referral centre, the Royal Adelaide Hospital, and it takes 15 minutes to fly there. We look at 3 parameters: how reproducible our measurements could be between us, what's the efficiency for our scans, and how many aneurysms we actually detect if we were to push this project. So 3 of us attended a point-of-care ultrasound course. It was a 2-day course, mainly focusing on point-of-care ultrasound modalities, and in particular for AAA, in terms of measurements and detecting pathology or leaking aneurysm, it was worth 2 hours. So we start on the transverse plane, scanning from the epigastrium, identifying the abdominal aorta, tracing all the way down to the bifurcation. We look at the image with the widest diameter, and particularly focusing on the infrarenal portion where most of the AAA happens. We measure the outer to outer wall of the diameter at expansile, and we document the maximal diameter each of us has measured. The globally accepted inter-observer variability has been set as 5 millimeters between sonographers and radiologists. However, it's been reported as low as 70% of reproducibility between sonographers from some studies. We recruited 2 groups of participants from hospital inpatients and volunteers from the community, and they have to be older than 50 years old and have no symptoms for AAA. So each of the operator would enter the patient's cubicle or enter into the room separately and sequentially. So we were blinded from each other's measurements. We had a separate data analyst to collect demographic data, as well as look up past imaging, including CT and ultrasound, to see whether there's an existing abdominal aorta diameter. Any suspected aneurysms from any of us would be referred for a formal ultrasound scan. So this was a 23-day study. We used day 1 to establish logistics within the hospital to perform the study and ensured uniform ultrasound techniques between operators. We had 3 days where volunteers could present themselves to the hospital to perform the study. There were in total 71 participants with 26 hospital inpatients and 45 volunteers recruited. So overall, 88% cases, all 3 of us were able to produce measurements within the clinical acceptable difference. It was up to 96% for volunteers and lower for inpatients, down to 73%. We identified our reproducibility by using the Bland-Altman plots, as you can see as an example on the right side. So the y-axis in millimeters represents the measurement difference between pairs of operators. And the x-axis represents the size of the abdominal aorta. The blue shade represents the limits of agreement, which is justified by the 95 confidence interval around the mean. So essentially, if the mean is closer to 0, it's better. And you would want the blue box sitting around upper limit and lower limit of 5 millimeters. So in comparing day 1 and the rest of the study, we found that there was significant improvement after day 1 of the study, where we established the logistics. So the left side is day 1. You can see the lines are separated from each other way further when compared to the right, when day 1 is excluded from the study. And you can see the dots are lying outside of the 95 confidence interval as compared from the left and to the right. And if you look closer, there's significant improvement in reproducibility if day 1 was excluded. We also compared between the 2 recruiting populations, and we found all the limits of agreements were within clinical acceptable difference, particularly for the volunteers. So what actually made the difference? The 2-way ANOVA showed us is actually day 1, where standardization of ultrasound technique was the main cause for the difference in measurements. 97% of our measurements were successful in attaining measurements, and the failed measurements were mainly due to presence of biogas, body hepatitis, and there was a gradual decrease of the examiner duration in accordance to the operator's experience. We detected 5 aneurysms, and 2 cases had no symptoms and no pass through AAA, and 1 case out of 2 was agreed by a radiologist of subsequent ultrasound. We think there is a potential for junior doctors to perform ultrasound screening, in particular for the rural population. We had great reproducibility after 1 day of ultrasound technique standardization. We had great scanning efficiency within 10 minutes, and we detected actually AAA is actually quite common in our recruited population by having this small sample. However, because of the lack of funding, we weren't looking at accuracy because we don't have the goals to compare against. Do I have to stop now? Okay, I'll continue very quickly. Sorry.
Yeah, just wind up now if you would, yeah.
Sure. So it's limited. It is a small study. We're not looking at accuracy, only reproducibility. And as the cost of two-way screening in a rural setting by junior doctors could be as cheap as $13. So we thought that we should not stop at junior doctors in pushing this project forward, and possibly further study on cost effectiveness and mortality benefits, in particular for rural settings, will be beneficial. Yeah.
Okay, thank you very much for that. One of the reasons that aortic aneurysm screening programs haven't become more widespread worldwide is that the rate and number of presentations of ruptured aneurysms has rapidly fallen over the last 10 to 20 years. And even in the countries where it's carried out, the cost effectiveness is in doubt. So one of your conclusions was this would be a cost effective measure. How do you justify that given the current situation with AAA?
So according to the literatures I've read, the main factors that affect the cost effectiveness is, one, there's a lot of incidental finding on CT abdomen, say abdominal pain. If they have a CT, they would already have the imaging of the abdominal aorta showing that whether they have not AAA. And the second thing is most of the study actually focuses on the metropolitan population where they have greater access to healthcare. The time to surgery for ruptured AAA is actually quite short for them to get operated on promptly. What we are trying to focus on is in a population where they are 4 hours away from a tertiary hospital, even by flight, is 50 minutes at least. From diagnosis of ruptured AAA in a country hospital where you can't actually get operated on, to be transferred there using 2 hours time frame to get operated on, compared to a metropolitan resident, time to surgery might be 2 hours. There is a significant difference from our point of view, and unfortunately, it has not been greatly looked upon, if you know what I mean, in the current situation, in the current literatures that I've read.
Okay.
Melody, I've got one question for you. This obviously highlights an area for education in the medical school setting, as well in teaching doctors, junior doctors, this skill. Have you looked into, how you could approach the medical schools and universities to try and get this kind of program involved into their teaching curriculum?
Certainly, this is one way to look ahead in getting a broader profession or a broader skilled scanner in performing this kind of study. The thing is, as Mr. Method has mentioned, the cost effectiveness of AAA scanning itself has kind of lost interest from the public health setting, that they don't think is cost effective anymore. Plus,
I'm actually talking about the skill of the ultrasound recognition, which you've highlighted through your study, that, junior doctors can actually learn that skill quite easily.
Yes, so we have tried to demonstrate this. The thing is, our study is limited because we don't have a gold standard radiologist to compare against. So our next step that I'm thinking about is to actually compare us with funding, compare us with the radiology measurements with the radiologists to generate a exact time frame that we think that we need for training. Say we need 6 hours of training with a radiologist, and then we are actually capable, rather than just pushing the junior doctors out there and then create a bunch of false positive ultrasounds and another ultrasound, which increases the cost. So I think comparing against with the radiologist would be the best training that we could get. In our setting, we had 2 hours worth of not so focused on measurements scanning, but to detect a leaking aneurysm. So there's definitely an area to look at. Yeah.
Okay, thanks for that. If we move on, Shaman Tantani is the next name on my list. Are you ready?
Yep, let me share my screen.
There we go. Nearly there. Yep, that's fine. Whenever you're ready.
Yep. Thank you for this opportunity to present my research entitled Quality of Life in Carers of Children with Esophageal Atresia. This research is done as part of my PhD, which investigates the management and diagnosis of esophageal dysmotility in children with esophageal atresia. So esophageal atresia is the most common congenital esophageal condition, which affects 1 in 2,600 newborns in Australia. The esophagus is not formed properly in this condition, and so the newborns have an inability to swallow, which requires an operation during this period. But despite successful surgery, 85% go on to have swallowing difficulties and esophageal dysmotility in the long term, even into adulthood. Just to remind everyone of the classification system, type A is esophageal atresia alone, type B is associated with a proximal tracheoesophageal fistula, type C, the most common, is associated with distal tracheoesophageal fistula, occurring in 85% of patients. Type D has a proximal and distal tracheoesophageal fistula, and type E is an isolated tracheoesophageal fistula. So the current literature focuses on quality of life outcomes in esophageal atresia patients, but there is limited data regarding the impact on the quality of life of carers. And so my study aims to assess the quality of life in carers of children with esophageal atresia, and to further assess the esophageal atresia subtypes for any potential differences. To put my study into context, this is done at the Royal Children's Hospital, which is the world-leading tertiary pediatric hospital. And we have the world's largest esophageal atresia database, started by Mr. Nate Meyer since 1948. We have an expert team of pediatric surgeons who operate on 20 to 25 such patients per year in Victoria alone. My study design is a prospective longitudinal cohort study, and I conduct the interviews with carers of esophageal atresia patients in person if they attend RCH for an appointment or over the phone. I enter their responses directly into this REDCap database that you see here, hosted by the Murdoch Children's Research Institute. In this study, type E is designated as controls because there is continuity of the esophagus from birth, resulting in less events of dysfunction or dysmotility for these children. The questionnaires I utilized include the parent experience of child illness, which examines the parental adjustment related to caring for a child with a chronic illness, measured over 25 question items, and includes the subscales of guilt and worry, unresolved sorrow and anger, uncertainty, and emotional resources. I also utilized the patient-reported outcomes measurement information system, anxiety and depression forms, which includes 7 and 8 items respectively and are person-centered measures. I've also included the pediatric quality of life inventory, which are parent proxy completion in this case, to provide some context of the responses for the parents. And so this PIDS-QL is a modular approach to measuring health-related quality of life in children and adolescents, and includes 36 items for children up to 1 year of age, 45 items for 1 to 2-year-olds, 21 items for 2 to 4-year-olds, and 23 items for 5 years and above. I interviewed carers of 100 esophageal atresia patients, including 86 mothers, 13 fathers, and 1 grandmother. It took me about 15 to 20 minutes per carer to complete the questionnaires. The demographics of the patients are as follows. There were 64 male, of which the median gestational age was 37 plus 4 weeks, and they had a median birth weight of 2.9 kilograms and a median age of 4.6 years at the time of the interview. Most commonly, we had esophageal atresia with distal tracheoesophageal fistula, and 30% of patients had associated anomalies. 57% had at least 1 esophageal dilatations previously, and 11% had a fundoplication previously. What I found is that there were significant differences when the patients were stratified by esophageal atresia subtypes. Particularly for the PECI, the subscale of unresolved sorrow and anger was significant, and for promised anxiety, this was also significant. However, there were no significant differences when associated anomalies were compared, nor when the requirement for esophageal dilatation was compared. With fundoplication, there was a lower PIDS-QL score for the physical scores in those 2 years and above, and in social scores as well. And when age alone was compared, there was a lower PIDS-QL score for physical and school scores for those aged 2 years and above. And as you can see in the graph here, the older the age of the child, the lower the score. And so to conclude, my study is currently the largest study of its kind, and I have identified esophageal atresia subtypes, previous fundoplication, and patient age as factors that had significant impacts upon the quality of life of carers of esophageal atresia patients. This finding has a potential to inform the counseling of parents of new esophageal atresia patients in the future. And finally, I'd like to acknowledge the people and the funding who have made this research possible, and I'll take any questions. Thank you.
Thank you very much. Has anyone on the panel got questions?
Yep, thanks, Sharman. What were some hurdles to conducting this research?
Yep, so it's very challenging with parents and children being involved, particularly because my research was part of a larger study where I utilized manometry to investigate these patients. So the recruitment was done side by side. And on the one hand, the manometry study, which I'll present at another session, was challenging to recruit parents to have their child take part in an invasive study. However, because the recruitment was done side by side, those who were not willing to take part in that were then more willing to just answer questions. And so in one hand, I think allowing me to do simultaneous studies side by side actually allowed my recruitment rate to be slightly higher for this study than I would have otherwise anticipated. And 15 to 20 minutes over the phone is something that most parents were very agreeable to do. However, I think there are challenges in interpreting how the family may give the responses, because I had 86 mothers and not as many fathers. And so I couldn't really compare the difference in how they might respond to their child's symptoms and how they might interpret them, because the literature does show that parent proxy forms may be similar when they're comparing mothers and fathers, but when they're comparing child to parent, for child and mother and child and father, that might be different. And so that's one of the challenges in interpreting what my study shows, because I haven't got enough data to say mothers and fathers are giving different responses.
Okay, and as you said at the beginning, there's a lot more data on quality of life in the actual children themselves.
Yes.
Does the quality of life in the patients, in the children, mirror that in the parents, or is it a different distribution?
So there is a difference, because what the literature shows that things like reflux can be a significant contributor, and a lot of those questionnaires in the literature utilize gastrointestinal specific questionnaires, but also PET scale is quite a common one, and I have used this to try and reflect some sort of comparison with the literature. And the literature is a bit different in terms of what you read. Sometimes age is a factor, sometimes age makes no difference at all. I have found that age is a factor, however, it's the older the child, the worse it is, where sometimes in literature it actually reports the other way around. So there are some similarities, but some differences depending on the aspect of the quality of life that we look at.
Okay, thank you. Any other questions? Okay, thanks for an interesting presentation.
Thank you.
And if we move on, Quinlan, lucky last.
Hi there, yes, good evening. Thank you very much.
Nice background. So you want to pull your presentation up?
Okay, there we go. So thank you very much for the opportunity this evening. It's a real honor and privilege. So my work looks at the application of machine learning to clinical decision support in neurosurgery and the application of artificial intelligence to the systematic review process. So with any presentation, it's useful to start with the why. So machine learning technologies are being applied to and having significant impacts across industries, and particularly in healthcare. So we were interested to see how machine learning had been applied to the field of neurosurgery, and how it could apply natural language processing, which is a field of machine learning, to augment the systematic review process. So this was the result of a partnership between the University of Notre Dame here in Australia and the Virginia Mason Medical Center in Seattle in Washington in the United States. So what is AI? So fundamentally at its core, artificial intelligence is about effective prediction. It consists of these three core elements: algorithms, computational power, and large data sets. And it can be divided up into three different types. So you've got supervised learning, unsupervised learning, and reinforcement learning. Supervised learning involves using data that is labeled. So for example, surgery cases where you know the complications, post-operative complications. Unsupervised learning is also known as clustering, and it involves the use of unlabeled data. The main language used in machine learning research is Python, and this is what it looks like. So algorithms, there are many different types of algorithms, and they demonstrate different levels of efficacy. And they're really just different ways of bringing numbers together statistically to affect prediction. So they range from traditional logistic regression through to support vector machines, random forest, gradient boosting machines, neural networks, all the way up to deep learning. Natural language processing sits at the interface between computer science and linguistics, and it can be used to understand language, generate language, classify documents, and retrieve information, particularly from medical records. So the analytical framework we developed was structured around the preoperative, intraoperative, and post-operative outcome prediction and prognostication phases, and this guided our analysis. We evaluated performance metrics for machine learning algorithms and wrapped up all the literature into a natural language processing analysis. So the selection process started with 6,800 articles and was whittled down to 70 that met inclusion criteria. So it was evident that the number of studies applying machine learning to neurosurgery is increasing exponentially over time. And there were many diverse data sources that we used to predict a wide range of useful clinical outcomes across neurosurgical domains. So predictors and data sources into the algorithm included demographics, clinical history information, radiology, geometry, 3D models, and psychometrics, and risk stratification scores. And outcomes predicted included survival, surgical success, satisfaction, pain, patient outcomes, postoperative complications, and risk stratification. So spine surgery saw the most prevalent application of machine learning technologies, as you can see here, followed by brain tumor surgery. And neural networks almost universally outperformed all other algorithms. You can see that it's beating logistic regression, support vector machines, and decision trees here. So there were performance differences between algorithms. So neural networks showed higher accuracy than logistic regression here, and support vector machines showed higher specificity than logistic regression. The first step in our natural language processing analysis was keyword identification, separated by surgical domain, which you can see along the top here. And this is an example in DBS surgery, the keywords that came out of that corpus of literature. So coherence metrics in the NLP analysis indicated corpus was best organized into 7 topics overall across all papers. And we conducted topic model visualization to enable interpretation of these topics that were derived from the unsupervised learning analysis. So you can see this one revolves around complication and function in spine surgery. So to conclude, our machine learning applications that we saw in the literature were diverse. Performance was high generally, and there are significant opportunities for future research. Natural language processing interestingly demonstrated utility in the systematic review process. And it was published last year in Neurosurgical Review. So just to wrap up, this is the standard model of medical care. So we take a history, we do an examination, we order investigations. The research evidence base informs our management plan, and we deliver care to But as you can see, I think there are some components missing. I think the future of medicine and surgery is going to be more powerfully influenced by sophisticated data analytics and AI augmentation, because it facilitates the delivery of personalized and precise patient care. So the future of surgery will involve a closer collaboration between clinicians and data scientists, in the humble opinion of myself and my research team. Thank you very much.
Okay, thanks for that interesting presentation. I will offer it up to the panel for questions.
Yeah, Quinlan, thank you very much for that talk. Neurosurgeons, we're very early adapters of AI and early adapters of technology. However, in our training, we're very, how we say, not so much anecdotal, but there's a lot of direct learning and education from the older teachers. Have you noticed any increasing uptake of this sort of technology, this sort of approach in your readings?
Yeah, so I think you're right. It's still early days with regard to the adoption of machine learning technologies, but there's also a lot of excitement. Absolutely, people are learning about it and beginning to apply it now. So across DBS, I'm working on a pituitary tumor database at the moment. So I think it's growing, but there is still a lot of opportunity to apply these techniques to neurosurgical data sets. And then also to develop useful clinical tools that can be applied.
Such as?
I think risk stratification systems are the biggest opportunity. So, if you sit down with a patient and use an algorithm-driven system to provide them with an accurate evaluation of the risk of complications, that can better inform the consent process and the treatment and treatment planning. So I think that's a real opportunity.
Yeah, okay, thank you. Any final questions from the panel?
It's quite a novel research idea. Where did the idea come from?
Yeah, good question. I think I really have to credit the team. You know, I'm lucky to work with a lot of interesting and diverse people, and I think, you know, to the theme of this session, which was, you know, collaboration for the betterment of patient safety in medicine. Our research team is multidisciplinary fundamentally. We have surgeons on the team, we have expert data scientists, we have engineers and AI specialists. And this work, you know, I think the most exciting part of our research, it really shows how collaboration can ideas and interesting research for the betterment of patients.
Okay, thanks for a really interesting presentation to finish off the evening. That is the last of the presentations for this evening. First of all, can I thank everyone who's presented tonight for all the hard work they put in. And we all realise this is an unusual time and a different way of doing research presentation meetings. But there's clearly a lot of hard work gone into this, so thank you to everyone. And I'd like to thank my fellow judges as well, and to thank Virginia and Catherine for setting up the sessions. The recording of this evening will go onto the college website, and we will, as we said at the beginning, remove the recordings of anyone who didn't wish for that to happen. The next and final session for the oral presentations is going to happen at 6 o'clock on Tuesday, the 29th of September. So once again, thanks to everyone for attending tonight, and thanks for all your hard work.